the MRI. So what do you think? Which one is superior, CT or MRI?
I think for students as well as for all of us, the investigation of choice is a CT scan.
Right.
HRCT is the investigation that we need to do for cholesteatoma evaluation and surgical planning. The role of MRI is in a different situation. Role of MRI, diffusion weighted images come into play if you have done a canal wall up procedure or if you've done mastectomy with cavity obliteration, where you cannot examine the cavity for possible recurrence of cholesteatoma. In those situations, if you want to follow them up, instead of doing what used to be a second look operation, you can do diffusion weighted MRI.
Right.
So for surgical planning, MRI is not the treatment of choice.
Right.
The MRI is only used in certain situations, like if you suspect recurrence and there are a lot of granulations and the cavity is full, you don't know whether it's cholesteatoma or something else. For hidden areas, you can use MRI in revision cases. But primary investigation for, I think, is a standard HRCT.
If you are operating surgeon, a CT scan is extremely helpful, and it is very difficult to take bony information from the MRI. So if you are planning for surgery, the good choice is CT scan. Regarding the consent, so we are interested to know how you counsel your patients that you are planning to do the modified radical mastectomy.
And I think it's a balance that you have to achieve, because this surgery has potentially a lot of serious possible complications of facial nerve damage, dead ear, damage to the dura and CSF leak. These labyrinthitis, these are serious complications. So if you tell that patient the possibility of all these things, then I think a lot of patients would choose not to have the surgery done.
Right.
So therefore, your counseling has to be very informed counseling. You have to give them some statistical data that this is the possibility of facial nerve damage, whether it's going to be, most likely it's going to be temporary, it recovers if it happens. Similarly, the risk of dead ear, whatever it is, 1% or whatever, but that's inexperience. But at the same time, you also have to tell them that the cholesteatoma in itself is likely to give you more damage and complications if you don't get it done. It's just like counseling a patient for laryngectomy. Although it may look very, very grave to the patient that this can happen and this can happen, but you have to tell them the other side of the story as well. And in informed consent, I think we must give them some data, some percentages that this is the possibility of 2-3 things I think we must list in consent form. The facial risk of facial nerve. But the only trouble is that the statistic data that you available comes from very experienced centers.
Sir.
So if you're talking about a guy who's a penis otologist says the risk is 1% and then you are a beginner,
yes, sir,
you give that statistical risk. So I think you have to be honest with that patient, that you tell them that. But I think everybody should make an effort not to have these complications.
Different departments have different protocols. Some do from the post-aurical approach, others do the end-auric. So what you suggest for beginners who are starting the mastoid surgery, they start post-aurical or end-aurical? We know that both approaches have different indications.
Yes.
So which one is safe for beginners?
I think one message is that you should learn both. Which patient should have an end-oral approach and which patient should have a post-oral approach depend on your training and your trainer and your mentor, as well as I think there is an emphasis now that one should have small cavity.
Right.
Either primarily you should do a mastectomy with a small cavity, or we should obliterate cavity in a way that it's not a big cavity which is a discharging. For beginners point of view, I think a safer approach is a post-oral approach, because it gives you a good exposure. You can expose the mastoid. You can do almost everything with the post-oral.
Right.
However, in certain situations, end-oral is difficult approach to learn. I've taught you guys, but that's not something which is taught everywhere. But in certain situations, like if you're dealing with an active cholesteatoma, it's a sclerotic mastoid, and if you want to approach from anterior to posterior approach, then end-oral is the approach of choice. Therefore, this is why I said the diagnosis of cholesteatoma is not enough. You need to know the extent of the disease. You need to know the pneumatization of the mastoid. You need to know the exact nature of ossicles involvement, any involvement of the tegment. So all these put together, I use all that information to decide before surgery whether I'm going to use end-oral or post-oral, anterior to posterior or posterior to anterior. And this is where I think we should learn both, because every patient would require a different approach.
Right.
But if you ask me which one is the easier, I think one should start with post-oral.
You may identify the lateral canal.
Yes.
And that is very important landmark to proceed further.
Because in post-oral, your angle is different. So if you're doing mastectomy with an end oral, I think as a beginner you may struggle, because to maintain the air canal and do mastectomy in experienced hands you can do that. But post-oral I think is something where one should familiarize with all the structures and the landmarks.
This is the single most important fear to the operating surgeon. What is your advice? We must identify the facial nerve. Either we identify its landmark first, or first facial nerve, confirm it with the landmarks. So what should be the approach?
I think it's facial nerve is, you want to see it first,
right?
But you're likely to see it last, because the disease is such that it usually covers that area. And I think the best thing is not to go for it first.
Right.
First, do a mastectomy, identify sigmoid sinus, clearly identify the lateral semicircular canal. If there is one most important landmark in mastectomy surgery, I think it's the lateral semicircular.
Right.
It can lead you to anywhere. It will tell you where the facial nerve is, it tell you the relationship with the ossicles. So if you identify that, what I usually suggest is that you clear the disease from all other areas and then come into the area of the facial nerve. One should know the anatomical relationship of facial nerve with the lateral semicircular canal. And what I usually teach is that remove the cholesteatoma from the mastoid, clear it, know where your facial nerve is, take the bridge down, and then start peeling off cholesteatoma from superior to inferior. As you peel it off from superior to inferior in the attic, automatically your facial nerve comes.
Right.
If you try to look for facial nerve first, it's impossible. So very gently with a cotton pledget or with the frying pan or whatever, once you've cleared the attic, try to peel the fascia, the matrix of the cholesteatoma down into the middle ear. Facial nerve is the first thing which uncovers.
Right. And there is a bleeding and the incus is absent. This is a difficult situation. In our last mastoid, it was very difficult mastoid. So there was no ossicles, it was only granulations, and there was no bony covering.
Was it cholesteatoma?
Yeah, that was cholesteatoma. So give some tip how to handle this situation.
I think granulations are more difficult than cholesteatoma itself.
Right.
Which means it's an osteitis, and if it's involving the facial canal, then it's going to be difficult to peel it off. One of the objectives in modified radical is that we want to clear the disease and we want to reconstruct the cavity.
Right.
With a graft like you've shown in the tympanic cavity as well as the mastoid air cells, mastoid cavity. But that is one situation where if you're not sure that you've cleared the disease completely, then I think one would be reluctant to reconstruct it.
Right.
Similarly, removing granulations, tough granulations from the facial nerve can be very difficult. If you've removed the cholesteatoma and the matrix and you're not sure about the granulations, at times it is safer to leave it there. I use very fine cotton wool balls, and you just gently scrape off,
right.
Not with the instrument, not with the needle, not with the frying pan. You just use cotton wool, just scrape it off the facial nerve if possible. As long as you don't damage the facial nerve bundle, you're not going to have facial nerve paralysis. And if you're really struggling, I think you remove as much as you can. Perhaps I would not graft that ear, right. And I would leave it open.